Fibroids, non-cancerous growth within the uterus, affects up to 70% of women by the time they reach menopause. Despite their prevalence, many suffer in silence, unaware that their symptoms have a name or that treatment options exist. In this report, we explore the nature of fibroids, their impact on women's lives, and advances in diagnosis and care. Through expert insights and personal stories, we shed light on a hidden health challenge. At age 32, she noticed her periods became heavier and more painful. Simple daily talks grew more challenging, fatigue set in, yet she believed this was a normal part of womanhood. Fibroids affect more than just the body. They impact work, relationships, and overall quality of life. Another woman describes a persistent sensation of pelvic pressure, likening it to carrying a heavy weight. Social events became daunting, fearing unpredictable bleeding episodes. Because symptoms overlap with other conditions, fibroids may be overlooked or misdiagnosed, leading to delays in treatment.
What we call growths or tumors that can be found within the uterus. They are not cancerous or almost never lead to cancers, but they're just tumors of smooth muscle origin with a little of connective tissue as well that grow within the wall, within the uterus, and they can be either found within the uterine lining, that is endometrial lining, that is the inner lining of the uterus, or the outer surface of the uterus, or within the muscle layer of the uterus. So with that, we can have fibroids that we call submucous. Those are the ones that appear to protrude within the wall of the endometrial lining. Those ones are inside the endometrial lining, inside the lining of the uterus. And then we have the intramural, those ones that are within the muscle layer of the uterus, that is within the myometrium of the uterus. And then we have the subserous fibroids. Those ones appear to be on the outer surface of the uterus. And then occasionally we may have pedunculated forms of the uterus, where a pedunculated form of fibroids, which are like stalk, they're like they hang out like stalk within the inner lining of the uterus or outer surface of the uterus. Those ones we call the pedunculated fibroids. In the medical field, we also call it leiomyoma, or sometimes we call them myomas.
Recent studies suggest that Nigeria has one of the highest rates of uterine fibroids compared to other regions. Research in Nigerian teaching hospitals reveals that fibroids are responsible for a large percentage of gynecological hospital admissions and surgical interventions. Women aged 30 to 39 are most commonly diagnosed, which highlights the role both genetics and environmental factors play in their development. This increased prevalence calls for a greater focus on raising awareness and improving healthcare services that specifically address women's reproductive health needs. Fibroids can range in size from a few millimeters to several centimeters. The location within the uterus varies. Some lie within the muscular wall, others beneath the inner lining or on the outer surface.
That would make you might have fibroids, because they can be as tiny as minute that even the naked eyes cannot see within the uterine cavity. And sometimes it can be as large as a grapefruit. So depends on the size. That's when you start elaborating or showing those signs and symptoms that most women would present in the clinic, in the gynecological clinic, with symptoms like one, heavy menstrual flow or painful menses could be one, and then two, they could have prolonged menses, that their menses could be longer than expected. Because that's another one. And then they could also have pressure symptoms. You notice that they're having lower abdominal pain, severe pains, and having issues, a difficulty urinating. Those are some of the symptoms. And then they could notice that their abdomen, their lower abdomen is getting increased in size. That's another one. And then they could have pain during sexual intercourse. It's also common, especially when they have pedunculated forms of the fibroids. They could have that. And yes, those are the common symptoms that most women present with. Women in their reproductive age, yes, they could have some form of fibroid, especially if you have those risk factors that are associated with. First of all, being a female, and then being of the black race, because it's more common amongst the black, and then the black and African, and then these fibroids. So that means some will have it and will not know they have it because it's not giving any symptoms, any sign. While some will come down with symptoms and present to the clinic with complaints.
At age 32, she noticed her periods became heavier and more painful. Simple daily talks grew more challenging, fatigue set in, yet she believed this was a normal part of womanhood. Fibroids affect more than just the body. They impact work, relationships, and overall quality of life. Another woman describes a persistent sensation of pelvic pressure, likening it to carrying a heavy weight. Social events became daunting, fearing unpredictable bleeding episodes. Because symptoms overlap with other conditions, fibroids may be overlooked or misdiagnosed, leading to delays in treatment.
Screening, most times when it's a clinical diagnosis, when clinical in the sense that the presentation, what the patient presents with, most times tie up. What we actually do, like some form of investigation to confirm, is a regular ultrasound scan that we do, that may actually show us. But if they are that minute, they might not really be obvious. But when the patient presents to the clinic with these complaints I've earlier outlined, and then you now investigate further by some form of radiological investigations like the ultrasound, abdominopelvic ultrasound scan, and it can be picked up from there, and appropriate treatment commenced. Fibroid can never, let me use that word, but in medicine, never say never, but it's mostly never lead to cancer. So, and sometimes if it doesn't present with those symptoms that I just highlighted, most women will not come to you in the clinic for you to diagnose them of having uterine fibroids. That's what I'm trying to drive at. So for those women, they don't have any issue because they are asymptomatic in quotes. Asymptomatic means they don't have any symptoms that fibroid is actually making them or causing. Okay, we could have the medical and the surgical. And then depending on our age, there's what we call expectant management. Expectant in the sense that, this woman she's almost approaching menopause, or let's say if she approaches, we know that with the withdrawal of the hormones, the fibroid will shrink over time. Or she's not that fit for surgery and she's approaching menopause. Okay, fine, let's see how we can manage expectantly. But aside that, the major treatments are medical and surgical. Medical involves administration of medications, drug, to actually help to one, reduce the size of the fibroid, which in this case is usually for fibroids that are not that big. Because when the fibroids are that big, this medical treatment often may not be advised. And sometimes you even use this medical treatment as an adjunct to surgery, because we want to shrink them to a point whereby surgery can be more successful. For the surgical options of management, we have the definitive, which is the one that we call hysterectomy, where we remove the uterus. Those are for women that have completed their family size. They don't have any any fertility wish again. And that's the definitive one, because removing the uterus, you're sure that this woman will not have fibroid again. Then we have the other one, which is more common, that is the myomectomy. That's removal of the fibroid nodules, an operation where we remove the fibroid nodules one by one and clear the uterus of any fibroid nodules we can see. Remember, I told you there are some that are so minute that we cannot see with the naked eyes. So the ones that we could see, we remove as much as we can, and then close up the womb, and then the man return to a normal lifestyle. And that one is what we call myomectomy. It's a common surgical option of management in this now climate, especially for women that still have fertility wishes, that are still in their reproductive ages and they've not completed their family size. So those ones, we carry out myomectomy for them. And one of the drawbacks there is that in some cases, or most cases, there's a tendency of recurrence of this fibroid. That's why I said the definitive is removal of the uterus. That is the definitive treatment, is removal of the uterus. Knowing that with that, the fibroid will not grow again, have no way to grow again. But myomectomy, in its sense, is a way of helping the woman because of the symptoms that she's having, the complaints that she came with, trying to remove as much as possible to alleviate or reduce those symptoms to the PRS. Symptoms like the heavy menses that she comes complaining with, or pain during sexual intercourse, or the pressure symptoms like constipation, and those are because of how huge the fibroids are. So we tend to remove those ones, knowing fully well that this woman still have option of getting pregnant again. More than 7 days, that's prolonged.
Okay.
When the menses run for more than 7 days, that's prolonged, because the average range is within 3 to 5 days. But we won't give that lapse of 7 days, so let's say okay. But when it's more than 7, that's prolonged. That's prolonged. That means she's having prolonged menses. He or she has to visit a gynecologist for experts or specialists advice after being reviewed properly.
Social and economic factors combined with cultural stigma can delay care and worsen outcomes. Fibroids may be common, but the effects are deeply personal. Increased awareness and early intervention can also transform lives.
A woman can get pregnant and also have fibroid in utero. That's the condition we call fibroid in pregnancy. And it's a two-way thing. The fibroid can affect the pregnancy, and then the pregnancy can also affect the growth of the fibroid. And so, the fibroid affecting the pregnancy, sometimes it can lead to miscarriages. Sometimes it can lead to early preterm delivery. Sometimes it can lead to so many obstetric complications that could arise early, even abnormal malpresentation, abnormal lie, even early rupture of the membranes. So many things could occur with uterine fibroid, and then there could be a very common one in the antenatal period, which is what we call the wet degeneration in pregnancy. This is when you come with severe pains during pregnancy as a result of the fibroid that's there, and that's usually an emergency that have to be managed in the hospital. And so that's the link between the uterine fibroid and pregnancy. It's at some points it tends to reduce. The fibroid tends to shrink as pregnancy progresses, but initially that pain, the wet degeneration will be there, and then if the fibroid is that big, and then if the fibroid is that big, it could cause these obstetric conditions I mentioned, like abnormal preterm births, that is preterm labor. There could even be miscarriages along the way, and so on and so forth. Like I said, it can grow big as a grapefruit or even bigger. So, and when they grow like that, most times they tend to distort the lining of the uterus, the uterine lining. And when there is distortion of the uterine cavity, implantation might be difficult, and likewise getting pregnant. Because when there is no implantation of the fertilized egg, pregnancy will not occur. So that's when we tend to link fibroid to infertility. Otherwise, without distortion of the uterine cavity, a woman that has fibroid can get pregnant. Fibroid can affect the pregnancy, and then the pregnancy can also affect the growth of the fibroid. And so, the fibroid affecting the pregnancy, sometimes it can lead to miscarriages, sometimes it can lead to early preterm delivery, sometimes it can lead to so many obstetric complications that could arise early, even abnormal malpresentation, abnormal lie, even early rupture of the membranes. So many things could occur with uterine fibroid, and then there could be a very common one in the antenatal period, which is what we call the wet degeneration in pregnancy. This is when you come down with severe pains during pregnancy as a result of the fibroid that's there, and that's usually an emergency that have to be managed in the hospital. And so that's the link between the uterine fibroid and pregnancy. It's at some points it tends to reduce. The fibroid tends to shrink as pregnancy progresses, but initially that pain, the wet degeneration will be there, and then if the fibroid is that big, and then if the fibroid is that big, it could cause these obstetric conditions I mentioned, like abnormal preterm births, that is preterm labor. There could even be miscarriages along the way, and so on and so forth.
Hi everyone, so today I wanted to come to you to talk about my experience with being pregnant and having fibroids. So I know that other women might be out there that have, shared the same experience as me, or might be going through pregnancy right now with fibroids, and you're looking for someone who has been through that. So I wanted to share my journey with what happened with me while being pregnant with fibroids. So first I want to start off by just saying, when I got pregnant, I did not know I had fibroids. I shortly found out a little couple weeks into my pregnancy. So let me start by that. So how I found out I had fibroids while I was pregnant was, so I found out I was pregnant. I think I was probably 4 or 5 weeks pregnant. Did a home pregnancy test, made an appointment to meet with OBGYN doctor. She told me that typically you wait until you're about 8 weeks before you're seen. So, they calculated based on my last period that I had to wait a couple of weeks before I came in to do my first ultrasound. I think I was about 1 week out from going to the doctor when one night I woke up and I was having severe cramping pain. Kind of also felt like somebody was stabbing me in my lower abdomen. So I got up, I went to the bathroom, and when I wiped myself, I saw a lot of blood. So of course I panicked. I thought I was having a miscarriage. I woke my husband up. I told him we had to go to the hospital. And so we went to the emergency room. And when we got there, they told me, basically they were going to do an emergency ultrasound to see if I still had the pregnancy, but they said maybe possibly I had a pregnancy that happened outside of the uterus. So they were thinking that maybe the baby was in my fallopian tube or something like that, and that's why I was having so much severe pain. I was in so much pain. I'm going to say that if I had to rate it from 0 to 10, it was, now that I've had a baby, I'm not going to say it's a 10. At the moment, it was a 10 to me, but pregnancy, labor is a 10. So I'm going to say this pain was about an 8. I got into the ultrasound, and shortly they told me, I saw on the screen that the baby was still alive. Nothing was wrong with the baby. The baby's heartbeat, that was the first time I heard the heartbeat. I had tears rolling down because I was so excited that the baby was okay. That's how I found out I had fibroids. So the doctor, reviewed the scan, the ultrasounds, and came in and told me, hey, you have fibroids. I actually had 3 that they found. They said 2 were really large. And so that was causing me so much pain that sometimes when women are pregnant, and have fibroids, that they experience severe pain. So shortly after, I ended up going to see my OBGYN. They confirmed that yes, this is what's causing you pain. The way they explained to me is why fibroids make you have so much excruciating pain, sometimes, not all the time in pregnancies, is that the fibroids are basically getting their nutrients, their blood supply from your uterus. And so when you get pregnant, what happens is that blood supply diverts to the baby. So now the baby is getting all that blood that was going to the fibroids. So essentially the doctor put it into me that the fibroids are slowly dying. So because they're dying, because they're not getting blood, that ends up causing women pain. After I found out I had these large fibroids, the doctor said that what would be the most concerning, what they would be monitoring me for, is that sometimes when women who have fibroids, what ends up happening is that the baby doesn't grow, doesn't start to gain weight. So because you have fibroids and that's taking some of that blood supply from the baby and nutrients, that the baby might end up growing smaller. Also because the baby doesn't have room in the uterus, right? So some of them also in your uterus, the fibroids are taking up space. So that also doesn't allow for the baby sometimes to grow as well. So that's what they said they would be monitoring. So I had more ultrasounds than what is usual for a normal pregnancy, and I know that's not typical, but the doctor was always trying to make sure that the baby was growing and that the fibroids weren't growing as well. So my fibroids actually didn't grow any bigger while I was pregnant, and my daughter was growing fine. So, but they still throughout the whole pregnancy kept having me come in and do extra blood work, extra ultrasounds, just to make sure the baby was safe. Now I do have to say that they were telling me in the beginning that, you experiencing this pain might not happen the entire pregnancy. Well, let me tell you, it happened the entire pregnancy. I have 2 kids. So this is my first pregnancy I'm talking about. That entire first pregnancy, I was in pain. And it wasn't where it was just like, oh, ow, oh. No, I was in tears some days and on the floor. And I was calling out of work some days because I just could not stand up because the pain was so excruciating. I would call the doctor and tell them I'm having so much pain. I would be on the phone crying, and the doctor would literally just tell me, all you can take is Tylenol. When I say that was so gut-wrenching for me, because I'm like, how can I be in so much pain? I'm in tears. I literally can't stand up and walk. I have to call out of work several times. And all you guys are telling me to take is Tylenol. And that Tylenol was not working. Maybe if the pain was an 8, it was taking it down to a 7. It was barely doing anything. So I would be laid out on a couch in tears. And what I started doing, because I Googled it, I'm like, oh, what else can I do? I looked up, what ended up popping up was, some people were talking about that their doctors gave them Percocet. My doctor was not for it. She said, absolutely not. I'm not giving you Percocet. That can harm the baby. And also, have addiction issues. So, okay. So also what I found out, which was besides medication that you can take, was I started doing a heating pad. So I went out, I bought a heating pad, and every time I got these severe pains and I couldn't go to work, I put the heating pad on me. And I'm going to tell you that probably dropped it down 2 more notches. So I went from an 8 to a 6 with a heating pad. Well, taking Tylenol and having a heating pad on. Or sometimes I'm going to say it was about a 5. So it was bearable with Tylenol and the heating pad. Now with the heating pad, you have to worry about, you don't want your abdomen to warm up too much because there is a baby inside. So I had to, alternate with it being on and off and kind of time it to where I didn't have the heating pad on too much and that I didn't fall asleep with it on because I didn't want to harm the baby. But those are the only 2 things that I did while trying to manage fibroid pain. You know what? I don't want to lie. So I am the type of person, when I had menstrual cramps, what worked for me was taking Aleve or Motrin. Tylenol never worked for me. So I asked the doctor, am I able to take Aleve? Am I able to take Motrin? And the doctor told me no, because those medications cause bleeding. So because they didn't want me to start having bleeding, they told me no, I couldn't take it. But because the pain was so unbearable, I'm not gonna lie, I did take Motrin sporadically. So I'm gonna say I didn't take it every day, and if I did take it, I only took it one time for the day. So this had to be when my pain was, I felt like, abnormally high. Maybe I felt like it was a 9. I would take Motrin instead of Tylenol, but like I said, I would only take it one time out of the day, and then for the rest of the day I was taking Tylenol, and that did help me. And I'm gonna say I had no bleeding, but that, of course, that's not something I'm gonna recommend that you guys do if you're experiencing any type of pain. You always want to do what your doctor says, but I just wanted to be truthful and say that I did take Motrin and it did help me. But for the most part, I was just doing the Tylenol and the heating pad. Moving forward from this, what I also experienced with having fibroids is that I actually gave birth to my daughter early. So I had my daughter, at 35 weeks and 2 days, and technically the doctor said that was considered premature because full term is 36 weeks. So I was a couple days away from being 36 weeks, so she came out premature. And she actually ended up spending 5 days in the NICU, not just because she was premature, but because she was having trouble breathing when she came out. So that, affected my experience with being a first-time mom greatly, because I didn't have my baby with me in the room with me. She was taken away from me basically almost immediately after I had her, and she spent 5 days in a NICU where they even put down a feeding tube into her nose because they said she was breathing so rapidly that it wasn't safe for her to feed. I was really sad about that. So I ended up being discharged from the hospital before she even could come home. So it was 2 days, while I was home before she was even able to be discharged and come home with me. But moving on from that, the doctor told me the reason why I might have went into labor early is because of the fibroids. That sometimes women who have fibroids give birth early, and that's because maybe she didn't have enough room to continue to grow, so my body basically went into labor. So that's something that also might happen to you, or you might have experienced. After giving birth to my daughter, I still was affected by fibroids because I continue to bleed. So you naturally bleed after giving birth to a child, yes. And then, but you have 6 weeks before you see your doctor, that next appointment, where in that 6 week span, you're supposed to naturally start to slow down on your bleeding and stop. Now, when I went in for my 6 weeks follow-up, I was still heavily bleeding. Doctor told me, oh, that's normal, you know, don't worry about it, we're not going to give you anything, your body will naturally stop bleeding. Well, I bled for 12 weeks. Yes, 12 weeks I was bleeding, and I got to a point where I was like, I can't take this anymore. Like, this can't be normal. I'm not going to continue to bleed. I made a doctor's appointment. I told them, we have to do something about this. I can't continue to bleed. So they actually put me on a birth control, and I'm gonna say within a week's time, my bleeding finally stopped. So I had to go on birth control, and for that reason of bleeding, and I actually stayed on that birth control for a couple months after giving birth, just because I was concerned that the bleeding would come back. So I stayed on that birth control. So that's another thing that might just happen with you having fibroids, is that it continues to affect you after you have the baby, just because you might start bleeding. So I want to let you guys know that the doctor told me that it's not uncommon for a woman with fibroids to bleed for 12 weeks after having a baby.
We could have the medical and the surgical, and then depending on our age, there's what we call expectant management. Expectant in the sense that, oh, this woman, she's almost approaching menopause, or let's say if she approaches, we know that with the withdrawal of the hormones, the fibroid will shrink over time, or she's not that fit for surgery, and she's approaching menopause. Okay, fine, let's see how we can manage expectantly. But aside that, the major treatments are medical and surgical. The medical involves administration of medications, drug, to actually help to one, reduce the size of the fibroid, which in this case is usually for fibroids that are not that big. Because when the fibroids are that big, this medical treatment often may not be advised. And sometimes we even use this medical treatment as an adjunct to surgery, because we want to shrink them to a point whereby surgery can be more successful. For the surgical options of management, we have the definitive, which is the one that we call hysterectomy, where we remove the uterus. Those are for women that have completed their family size. They don't have any any fertility wish again. And that is a definitive one, because removing the uterus, you're sure that this woman will not have fibroid again. Then we have the other one, which is more common, that is the myomectomy. That's removal of the fibroid nodules, an operation where we remove the fibroid nodules one by one and clear the uterus of any fibroid nodules we can see. Remember, I told you there are some that are so minute that we cannot see with the naked eyes. So the ones that we could see, we remove as much as we can, and then close up the womb, and then the woman return to a normal lifestyle, and that one is what we call myomectomy. It's a common surgical option of management in our climate, especially for women that still have fertility wishes, that still in their reproductive ages and they've not completed their family size. So those ones, we carry out myomectomy for them. And one of the drawbacks there is that in some cases, or most cases, there's a tendency of recurrence of this fibroid. That's why I said the definitive is removal of the uterus. That is the definitive treatment, is the removal of the uterus. Knowing that with that, the fibroid will not grow again, have no way to grow again. But myomectomy, in its sense, is a way of helping the woman because of the symptoms that she's having, the complaints that she came with, trying to remove as much as possible to alleviate or reduce those symptoms to the barest. Symptoms like the heavy menses that she comes complaining with, or pain during sexual intercourse, or the pressure symptoms like constipation, and those are because of how huge the fibroids are. So we tend to remove those ones, knowing fully well that this woman still have option of getting pregnant again. Very, very important question you just asked, and we've come across this so rarely, especially when we go to outreaches like this and we encounter these women that have been taking some herbal concoctions over time. I want to say this, it's very, very dangerous. It's very, very dangerous in the sense that those drugs, one, they don't shrink those fibroids. That's the first thing. Two, they in the long run harm your kidneys and give rise to a lot of the kidney issues where you see when people having here and there, they're having chronic kidney diseases and all that because of those medications that they're taking. Now, what those medications won't do to the fibroid itself is like it makes them to be matted together, especially to the uterine wall, that when we want to intervene surgically to get them out, it's usually very difficult because they're already matted together inside the sometimes in the endometrium, or even in the muscle layer of the uterus, and removing them usually very difficult. Aside the other health complications that these herbal drugs that these women are being given will cause to their health. So I would want to say that it is absolutely wrong. It is not advised. No herbal concoction can actually cure or treat fibroid. It is a condition that should be managed purely by a doctor, a medical doctor, especially a gynecologist. There's no specific age, but we just know that women of reproductive age actually are prone to having fibroid. As long as that means if you're a teenager, the likelihood of you having fibroid is not there. But as long as you are in your reproductive age, meaning from maybe 18 years to maybe 35 or more before you approach your menses, as long as you're in your reproductive, before you approach menopause, as long as you're in your reproductive age, there's a likelihood of a woman developing or having uterine fibroid if he or she have the risk factors that we've mentioned earlier. To run down some of those risk factors, we mentioned the race. You've been nulliparous. You've not had a child before, you had your menses quite early, you're probably obese,
those are the risk factors that you are on hormonal therapy. Those are some risk factors that predispose you to having fibroid. And then the family issue, important, because if you have a mom that had uterine fibroid, the likelihood of you having uterine fibroid, is there. Or you have a sister that have, the likelihood of you having is there. So those are the risk factors. And so when you are predisposed to those risk factors and you are in your reproductive age, then the chances of the woman increases compared to those that may not be in their reproductive age, or even though they are in their reproductive age, do not have these risk factors associated with fibroid. Managed, they can be linked to such to actually help in counseling them to understand that it's something that can be managed medically, and at the end of the day, with no complication. Just to be prompt at presenting to the medical facility, be seen by a medical doctor who will evaluate you properly, counsel you, and give you the best of medical care. It's not something that it's a death sentence, because in a woman's lifetime, it could happen.
If you experience symptoms such as heavy periods, pelvic pain, or pressure, please consult your healthcare provider because help is always available. Thank you for watching. I am Emedion James, reporting for Spectrum TV.